The next speaker is also from MedAustron, Medical Director. It's my pleasure to welcome Carola Caucig, and she will give us some insights on the pediatric treatments performed at MedAustron. Are you there, Carola? Yeah, I can see you.
Yes, I'm there. Thanks a lot, Sammy, for introducing me. And also thanks a lot for the invitation, giving me the opportunity to share our experience with pediatric cancer patients at MedAustron. And also thank you for being so flexible, because I'm a few meters behind Piero on the road, because we just came from our national meeting. So I will now start to share my screen. So pediatric cancers, as you already heard, are a rare disease, a very heterogeneous group of malignancies with an increasing incidence due to better screening and diagnosis since the 1970s, but also an increasing overall survival since then due to better treatment modalities and interdisciplinary treatment concepts. So this increasing incidence is, but this is also associated with an increased incidence of therapy-associated late toxicity and chronic health conditions, which lead to psychosocial burden of survivors and their families, but also financial burdens for our healthcare systems. I'm sure that a lot of you are aware of Kevin Oeffinger's work from the Childhood Cancer Survivor Study Group, which showed that up to 2/3 of childhood cancer survivors suffer from chronic health conditions, whereas up to 1/3 really severe chronic health conditions such as cardiac problems, pulmonary problems, but also secondary cancers. So what happened? How could we go on with this? So the thing, so pediatric oncology or pediatric therapy concepts, modern therapy concepts, try to maintain this excellent local control and overall survival up to 80%, 90%, depending on the histology, but also try to reduce this long-term toxicity and morbidity due to the therapies. So PEDs are normally treated within international standardized concept and therapy protocols with that aim for this strategy. So we have interdisciplinary strategies and multimodal therapy or risk-adapted strategies, response-guided therapies like we do in Hodgkin's lymphoma, pediatric Hodgkin's lymphoma, which also the experience from the pediatric later led to a better therapy concepts for adult patients. But what is what can radiotherapy or radiation oncology do besides reducing the indication, reducing field sizes, going from extended field, involved field to involved node in, for instance, pediatric Hodgkin's lymphomas, also reducing dose. So another strategy is to use protons whenever available. And because if you have them, you should use them. Like, and in Austria, we're very lucky because it's very easy to access for the access to particle therapy for pediatric patients. So this recommendation also leads to the consensus statements from the PTCOG pros and EPTN that even though there is not clinical data or not enough clinical data, no randomized controlled trials, it is due to the physical properties of protons, kids should get particle therapy. And this is, by the way, our testimonial. Her name is Fanny, and we have the allowance from the parents that she is, for the moment, our testimonial to show you also how we treat kids at MedAustron. So what are these late effects radiotherapy is leading to? This is from the homepage of the Little Fighters organization, which gives you a very nice overview on wherever we treat, there is the risk of toxicity. So we should really try to keep the irradiated volume as small as possible. So we were talking about the incidence of secondary malignancies, and there is already evidence and that the use of particle therapy is leading to an reduced incidence of secondary malignancies, which over all cancer types, and which for me at least seems to be very obvious, because if there's radiation, then there is risk of secondary cancers. If there's no radiation, of course, there is no risk. So if then the volume is smaller, then probably also the risk is reduced. Examples of pediatric cancers that are treated at MedAustron and are also in other countries and centers is, so if we talk about pediatric cancers, we have the most common is leukemia, then brain tumors and other central nervous system tumors, lymphomas, and Ewing sarcomas. And these are disease that can occur in adult and in pediatric patients. Cancers that mainly occur in children are neuroblastomas, Wills tumors, and rhabdomyosarcomas, retinoblastomas. So brain tumors and Ewing sarcomas, lymphomas is something that you also see in your adult patients, but also in the population of the AYAs, so the adult young adults. So rhabdomyosarcomas are mainly childhood cancers. The diagnosis is in the 50% in the very young children in the first decade of life. So we really have the little ones, the babies. The site of the tumor is in 25% head and neck parameningeal, so an area which is very sensitive to radiation in terms of toxicity, in the GU, and 13% in the extremities. Histological characterization is we can distinguish between alveolar, embryonal, spindle cell, and sclerosing and pleomorphic sarcomas based on this is according to WHO classification. Embryonal rhabdomyosarcomas are associated with a better prognosis compared to alveolar in pediatric patients, whereas if they occur in young adults, the alveolar have a better prognosis compared to the embryonal. There's the new classification based on the FOXO gene, which is also now used as a better prognostic factor. So all children with rhabdomyosarcomas require multimodality therapy. So with systemic therapy, chemotherapy, in conjunction with either surgery or radiotherapy, normally in week 13, sometimes also both, to maximize local control, tumor control, while not increasing the toxicity. Surgical resection is only performed before chemotherapy if it will not result in disfigurement, functional compromise, or organ dysfunction. But this is the strategy in general in pediatric patients. And if it is not possible, then only an initial biopsy is performed. The goal in rhabdomyosarcomas is, or to, especially because the children are so young, to treat the tumors without doing harm to the children. And these tumors are very sensitive to chemo, so normally they respond very good, so that in the week 13, where the local treatment normally is performed, the tumor already is a lot smaller, so that you have your treatment field, what the radiotherapy target is is also smaller compared to like initial volume. And if possible, if resection is performed, it is at that time also easier. Regarding international therapy concepts in Europe, the for RMS protocol is open for rhabdomyosarcomas, and is an actually very interesting protocols also for radiation oncology, because radiotherapy, they have two steps of randomization. First is pre-op versus post-op randomization, and in case of high local failure risk is standard dose 50.4 versus dose escalation 59.4. So it will be very interesting to see the results of this trial. And in all pediatric cancer trials or studies, protons are allowed, the same like photons. So there is no difference. So this is an example of a pediatric patient, a 10-year-old patient with a rhabdomyosarcoma at diagnose with involvement of the orbits and the paranasal sinuses. And what you see is the good response to chemotherapy. And this child was treated within the FAR RMS protocol, and then no surgery was performed. So the patient had a consolidating proton therapy in the dose escalation arm with 59.4. This is our treatment plan. Of course, particles also cannot create miracles. We also have areas where the dose is given to normal structures, but we try to reduce it as much as possible. So the next group is the Ewing sarcomas I would like to talk about. Because
Short reminder, Carola, just 2 more minutes, so
okay.
Please keep in mind, yeah? Thanks.
Yeah. Okay, 2 more minutes, so then I will skip the Ewing sarcomas. I will just point out that this is the disease of the older children. Dose escalation is leading to a better local control. So this is the window of opportunity for particles, because it's easier to do dose escalation if you're close to organs at risk. So the new protocol we are using in Austria, and also Europe-wide, is the Ewing protocol. All these new protocols have in common that they have a prospective RTQA, because it's pediatric cancers are often a rare disease. And to have the most experience, and that you send upfront your target and your treatment plan to the Quartet quality assurance platform from the ERTC, and within 2 days you get back the feedback regarding the target definition, but also your treatment plan. What is interesting is that both Raptor protocol and Ewing protocol are open also for young adults and adults. So even if you don't treat pediatric patients, if you have an adult or young adult with a pediatric cancer, you can treat these patients within the protocols. This is an example of a pelvic Ewing sarcoma with a plan comparison photons protons, and as expected, you can see a better sparing of the normal tissue, especially the bowel, but also the femoral head and the genitals. Then I will, pediatric CNS tumors, like also in adults. If you have a CNS tumor with a good prognosis, you should try to, if possible, to use particles because of the normal sparing of the non-involved CNS. This also, and there is evidence for this. There is the work of Torren York for craniospinal. She compared proton data with a historic photon cohort, and she could prove that there is the equivalent local control with minor IQ decline, minor neuroendocrine deficiencies, no cardiac, pulmonary, or GI toxicity on a long term. So, well, I will also skip this because what is more important, I would like to tell you now how pediatric radiation oncology involved or included particle therapy over the years. So Austria is very small. We have about 9 million inhabitants. The incidence of pediatric cancer is about 320 per year. All over Austria, we only have 2 specialized pediatric cancer centers, and we have 2 national tumor boards, one for CNS and one for non-CNS pediatric cancers. And in both of these international national tumor boards are in Vienna at the Medical University or at St. Anna Kinderspital. Then in addition, the distance between the centers in Austria is not that big. So for instance, from Innsbruck to go to Vienna is about 450 kilometers. So that's something that's possible, although they have the clinic there, but we are located here in this area in close to Vienna, so we also can treat patients from other parts of Austria. Particle therapy or proton therapy is totally covered in Austria by the Austrian social insurance authorities, which are also we have a central association of Austrian social insurance authorities. So there is for everybody the same possibility to get treatment. So our center was opened in.
Please wrap up, Carola.
Okay, in 2016. Since then, we started to treat pediatric cancer patients, and now we treat up to 100 pediatric patients per year, except CSI and whole lung. But this has, so this means that almost every child that requires radiotherapy is treated at our center. So proton really became standard of care, and it's based on the good collaboration we have, and also that children are treated within the trials. We use mainly protons, and we have our anesthesia team, and we treat up to 6 to 7 pediatric patients in anesthesia per day. Chemotherapy is given on the weekends, if necessary, in the pediatric cancer centers, and during they have their weekly follow-ups with the dedicated pediatric nurse, but also with the doctors. And of course, we also try to spoil them, and they get their goodies, and they get an award when they finished. And we have some pediatric projects at MedAustron. We have a register where we also include the pediatric patients. We have a collaboration with Hungary. We have the National Center for the IUing and the firearms, the neuroblastomas, SIUP, and Veritas. So we also treat neuroblastomas. We also treat Wilms tumors with particles. And our own project is also
I'm really sorry, Carola.
Yeah.
We have so many interesting talks to go. I'm very sorry to interrupt you here. Thank you very much for your nice talk. Thank you very much for showing us the broad variety of tumors that are you treating, and especially how you're organized in a country as Austria. And I think it really emphasizes the need of multidisciplinary collaboration. And this is something really that is lived all day in care of pediatric oncology. Are there any questions from the audience?
Any questions? Thank you very much. But I would like to say that we wish to have the same thing. We're a country with the same population, so we need something like that. It's a very good program. We have the same number of children with cancer, about 3 to 350. So I think that this could be possible to do it in Greece as well.
Yeah, I think if you have, if you have a small country, it really is the opportunity that if you talk a lot to the centers, that you centralize the treatment. And it's also the matter of experience, because to treat 100 PEDs, I mean, it's if you would distribute these 100 PEDs on different centers, with the experience is lacking also because it's such a heterogeneous group.
Yeah, thank you very much again, Carola.
Yeah, thanks a lot, and also sorry for talking too much.
Thanks, safe life. Bye-bye.
Thank you, bye.
We continue.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.